Hello, everyone. Welcome to the Department of Psychiatry and Behavioral Sciences Grand Round Series. My name is Joe Ceramelli. I oversee Grand Rounds for our department. Today is a joint Grand Rounds with the Department of Global Health. It's a joint Grand Rounds. We did this once last year and it went well, and we're repeating it again this December. And a couple of things just to walk through some details of our Grand Round series. We've got a general theme that we're trying to have presentations on for this year called Next Steps in Care. And there's a core group of us, including Samhara Braha and Mike Walker, that work on Grand Rounds each week. We archive our presentations on our Grand Rounds website. And I want to acknowledge funding for the series from the Ripley Fund and from different institutes and centers in the department at times, such as the Garvey Institute for Brain Health Solutions. I'll post a link in the comments box towards the end of the presentation for an evaluation form. It's just 4 or 5 questions about the presentation. It's a feedback evaluation. Please complete that at the end of the presentation, or you can send me any comments directly as well. During the presentation, you can type questions or comments into the Q&A or into the comment box, and I'll help to moderate that discussion at the end. And now I'll turn it over to Dr. Jason Bestie to introduce today's speaker.
Great, thank you, Joe. As Joe mentioned, my name's Jason Bestie, and I'm an infectious disease physician in the Division of Allergy and Infectious Disease and in the Department of Global Health. And on behalf of the Department of Global Health, I'd like to welcome you to a very special global health interdisciplinary collaboration, as this is our first joint Global Health Grand Rounds event for this academic year, as Joe mentioned, co-hosted by the Department of Psychiatry and Behavioral Sciences and the Department of Global Health. We're really excited about this collaboration between our 2 departments, as global mental health contributes to a large burden of disease around the world and is one of the priority areas in the Department of Global Health. It is my absolute pleasure to introduce you to our speaker today, Dr. Marian Brooks. Dr. Brooks is a pediatrician and an adolescent medicine specialist at the Children's Hospital of Philadelphia, and the lead pediatrician and research director of the Botswana UPenn Partnership. She attended the University of Pittsburgh on the Helen Feisen Scholarship for her undergraduate studies with majors in neuroscience and the history and philosophy of science, and later received a master's degree from Pitt with a focus on clinical science. She went on to medical school at Ohio University Heritage College in Osteopathic Medicine and completed her residency training at Cooper Children's Regional Hospital in Camden, New Jersey. She's a board-certified adolescent medicine physician, having finished her fellowship at the Children's Hospital of Pittsburgh. Currently, Dr. Brooks spends most of the year in Gaborone, Botswana, doing mental health services research for adolescent and young adults in Botswana, work that she started as a CHOP David Pincus Pediatric Global Health Fellow. She is profoundly interested in closing the well-being gap between youth and high and lower income settings. Dr. Brooks, thank you again for taking your valuable time to speak with us today, and we're really looking forward to your talk. And I'll hand it over to you.
All right. Can you hear me? I actually got booted up for a second. It was nerve-wracking.
Yes, we can still hear you and see your screen.
Great, wonderful. All right. Slideshow. All right, so as you just heard, I'm Marian Brooks. I'm an adolescent medicine specialist, and I primarily work in Botswana, but I also spend about a third of my time, a quarter of my time in Philadelphia at the Children's Hospital of Philadelphia, doing adolescent healthcare. So today I'm going to talk about the research work that I do in Botswana, which is related to implementing a lay counselor program in Botswana. The presentation I'm going to give you today is about the lessons that we've learned in implementing the program, as I'm sure many of you have heard about some of the science behind lay counselor programs. I want to get into how we think about and how we've been approaching and what we've learned from implementing a lay counselor program in Botswana. So I just want to acknowledge that this work is not done by me alone. These are my primary research team, the intellectual giants of the team. So Many of you have probably heard about the friendship bench, and the friendship bench is sort of the one of the primary examples of a lay counselor-based intervention that's been extremely successful in Africa. And it's based on other lay counseling and lay health worker interventions, but essentially has become sort of the shining star of lay counselor programs in our part of the world. So this friendship bench is a project spearheaded by Dr. Dixon Chibanda, who is a psychiatrist in Zimbabwe. And he worked with some community health workers to develop a program to treat mild to moderate mental illness and to prevent serious mental illness. This friendship bench intervention essentially trains community health workers in problem-solving therapy. And problem-solving therapy is a standard lay counselor therapy approach that has been used in other lay counselor programs as well. The benefit of using problem-solving therapy in a lay counselor program, particularly in settings where you're using lay counseling to bridge the professional gap, which the professional gap exists everywhere, but in low and middle income countries, it is often enormous. So the benefit of problem-solving therapy is that it can be easily protocolized, and it has been. The steps of problem-solving therapy that are often taught to lay counselors are essentially teaching them to help a client clarify and define a problem, establish achievable goals, creating multiple solutions, aka brainstorming for solutions, implementing a decision-making structure, choosing a solution, and then essentially action planning. And then the next time they're seen, they evaluate how that problem-solving activity went, or they evaluate the outcome. It's been manualized for lay counselors by the Friendship Bench and other lay counseling studies, but is something that is used, again, widely, particularly in our region and in other low and middle income countries. The benefit of problem-solving therapy and why it's often used in low and middle income countries is because in a lot of places, the community health workers are going to have a variety of different educational backgrounds. And so having an easily protocolized therapy method allows for lay people of a variety of different backgrounds, some people with only a secondary education, to be able to use an evidence-based skill with other people. It's obviously evidence-based with the CBT framework. And the other reason it's really well seen as a primary example of a good model for lay counseling-based interventions is because you don't have to be a professional at figuring out what diagnosis is potentially at play. So problem-solving therapy is going to work for many different types of problems that are presented. And a lot of times when I present to people who have backgrounds in therapy and in mental health, the first thought that they have when they're thinking about lay counselors is, well, will those lay health workers be able to identify the right diagnosis and then give the right treatment based on the right diagnosis? But problem-solving therapy allows for some wiggle room there so that the lay counselor can sort of just focus on the skill building as opposed to trying to do the more complex skill of diagnosis. And the primary goal is to promote adaptive problem solving, which, as we know, is something that is helpful even to people who are not struggling with mental illness or symptoms of mental illness. So for my study, I wanted to understand how we can use a lay counselor-based process in Botswana. And for those of you who don't know, Botswana is a country in Southern Africa. I guess it's been in the news a lot recently. That is about the size of Texas. It has a population of about 2.3 million people. It is growing in its medical professional infrastructure, but there are no child psychiatrists in the country, for example. There are several social workers, some that are trained and comfortable with therapy, some that are not. There are probably about 15 psychologists, some who are comfortable with young people, most who are not. And there is no, at present, formal infrastructure for other disciplines to gain skills in therapy and then get licensed. So the middle ground that has been seen is that master's level psychology students will often be able to be licensed as clinical therapists. So I wanted to see, how do we use lay counselors to bridge the gap for adolescents and young adults in Botswana, where with that gap of professionals for all people, it's particularly profound for young people. So we got a bunch of stakeholders together and said, what do you want us to know about youth mental health needs in Botswana? And so we got folks together, created a theory of change map, which I'll show you in a moment. And that allowed us to implement a lay counselor-based intervention based on the recommendations of that group. And it was a pretty intensive process. We wanted to make sure that we weren't coming in and delivering the friendship bench, for example, as it was delivered in Zimbabwe, with the same types of lay counselors, with the same exact training, because we were targeting a younger group of people. We were targeting people living with young people living with HIV, and we wanted to make sure that the intervention traveled well, given the cultural nuances that are different about Botswana. Botswana is Zimbabwe's neighbor, and so there's probably going to be more cultural similarities than in some other countries, but there are a variety of differences in the groups. And so we had about 7 meetings with them, 5 preliminary meetings, and then 2 that were follow-up after we first implemented our version of this lay counselor program that was based in the friendship bench. So we got some stakeholders together, and all the photos you'll see are shared with permission, and none of them are clients. We got some stakeholders together to try to understand what are the needs of mental health, what are the mental health needs of young people, particularly living with HIV, but all young people in Botswana. And to the left here, you can see a variety of professionals, older, middle-aged women who were part of that, organizing that stakeholder group. None of these were official parts of the stakeholder group, because that we promised them that confidentiality. To the right, or my right, you see a group of young people. These young people ended up being our lay counselors, and they also served as a youth advisory board for the implementation of our project. So this is the change map that we created with the feedback from the stakeholders. And essentially what they told us was that if we were going to be doing a lay counselor-based program for youth either with or without HIV, but primarily with HIV in Botswana, we were going to have to understand that there was a lot of issues with lack of knowledge about mental illness, stigma towards mental illness, and that fragmented mental health services was going to make it difficult for people to buy into mental health services, because they will think that it's going to cause a significant burden to their lives because of the way that they've had to try to receive mental health services previously. So for example, if I have a patient in Botswana that I see, a 13-year-old who's struggling with depression and who I want to see a psychologist, I often will have to send them to an institution that's outside of my own institution in the private sector, because the psychologists in the hospital that I work in don't see anybody below the age of 16. So what they kind of guided us on is, we said, okay, if we had a lay counselor program, what would you recommend? And some key areas are that they thought that our lay counselors, if we were targeting young people, should be young people. They emphasized that in the other study in Zimbabwe, in the friendship bench in Zimbabwe, the lay counselors were older women. And so our stakeholders said that doesn't work in Botswana. Young people and older people have a communication gap that would be, in their opinion, not easy to surmount in an intervention that's 4 to 6 sessions long. So they recommended that we seek out young adults to be the lay counselors, and so we called them near peer lay counselors. They also said that they thought that a secondary school education, so high school completion, was adequate, and that they had shown some leadership. Those were the qualifications that they would seek. They asked that we train the lay counselors well. They asked that we support them with debrief sessions and counseling sessions for themselves. They asked that we position the benches that the counselors would sit on, or the spaces that the counselors would meet clients, in places that were different from what they're used to, but also accessible. That maintaining participation would require that we were flexible, and that there was a high quality product, and that we would measure things like quality improvement, client testimony and feedback, and skills and goal setting, and that they believe that these things put together would help us to provide mental health services for adolescents in Botswana, and also educate the community on mental health and mental illness. So that was a change map that we made, and I'll show you this again as we go along, and I show you how we kind of implemented each of these recommendations. So I'm going to talk to you about contextual factors using the Reaim framework. In the Reaim implementation framework, and this is the enhanced Reaim framework that you're looking at now, but it allows you to sort of think about implementation in a way that emphasizes some of the most important considerations when implementing an evidence-based intervention. So Reaim is reach, effectiveness, adoption, implementation, and maintenance. And I'm going to go through each of those sections for how we've gone about doing this work of implementing a lay counselor-based intervention for youth in Botswana for each of those categories. But what I want you to be thinking about as I'm going through is some of these overarching issues. So how is this intervention sort of making it in the community? How is it penetrating the community? How representative is it? How and why is it working or not working the way it's working? Any adaptations, cost, benefits, and values? And I'm going to try to make sure that I share each of those sections with you all. So reach is about getting a proportion of people or people in your intervention that are representative of the people that you want to be reaching. And the important thing to note here is that there are two targets for reach for us on the individual level. One target is lay counselors. So we wanted to make sure that we had lay counselors that were also representative, mostly because we had a theory that the lay counselors themselves would benefit from being lay counselors. So young adults are often also struggling, as we all know, with mental illness, or, struggling with the antecedents to mental illness. And we thought that being lay counselors could help them to gain skills on their own and also provide skills to others. And it turns out that that was true in a number of ways. And then on the client side, we wanted to make sure that the reach was representative of clients. And we wanted to make sure that it was responsive to our feedback given to us by the stakeholders. So for the lay counselors, we wanted to make sure that we could get the lay counselors that fit into these qualifications that they recommended. And for the clients, we wanted to make sure that we were getting the clients that had burden of mental illness. And part of the reason that we focused on youth living with HIV is because we knew that that burden it was high. So what was our reach? So we ended up recruiting 20 lay counselors for our pilot program, and it's pilot. So we are very granular with our information because our sample sizes are quite small, but it has helped us to be able to understand what works and what matters. So for our lay counselors, remember we wanted to see young adults who had at least a high school education, who had shown some leadership, things like that. So we actually were able to recruit half males and half females to be trained in the problem-solving therapy manual that was actually developed by the Friendship Bench. So the Friendship Bench team actually came and did the training for our 20 young people. And you can see here that the age range was actually a little higher than 18 to 25. It was 18 to 28. And once we completed the training, we actually did an assessment where each lay counselor had to demonstrate going through a mock session with a mock patient that was then scored by two psychologists on a standardized scoring sheet. After that assessment, we were able to keep 12 of our 20 participants. And I show this, the people struck are the people who did not pass the exam. And I just show this to note that most of them were high school completed. They came from all age ranges. One of them was a college graduate. But there is no rhyme or reason to who didn't make it. And I think that that's important. The Friendship Bench in Zimbabwe, the lay counselor program, formerly known as the Friendship Bench in Zimbabwe, has also just started working with young people. And their cohort is all psychology students in the local university system who they're working with their young people. So what I love about this is that the stakeholders thought that having high school education was adequate and that these young people would be able to learn, and they did. So when it comes to the reach of the client side, we wanted to make sure that we understood exactly what the need would be. So we did screening in the HIV clinic that was nearest to where we were operating. And we found that as predicted, the highest rates of anxiety and depression were symptoms of anxiety and depression, because they were just based on scales and not interviews, were in 20 to 25-year-olds, followed closely by 16 to 19-year-olds. And so we wanted to make sure, and there is a gender predilection for females at 1.5 to 1, which is actually lower than most gender differences between depression and anxiety. But in this group, this is what we saw. So females slightly more than males, older teens and young adults were the clients that were most in need. And these are the clients that we actually targeted for our first rotation of the lay counselor program. So in our pilot, we had 35 participants. The average age was 20. Our 17, we didn't have anybody below the age of 17. 40% of them were 17 to 19, and 20 to 20, and 60% of them were 20 to 25. They were half and half male and female, and most of them were unemployed, and that made them more available for the study. What I think are key components, so the why of the reach, are that this cohort of people who were engaged in the lay counseling therapy with problem-solving therapy and then did 4 to 6 sessions of problem-solving therapy, those people wanted to get therapy. They were yearning. In fact, we had many requests for for therapy before we started formally. And so these people had positive ideas about how therapy was going to help them, which is not surprising. But it is good to know that even in Botswana, our young people, at least our cohort of young people thought that therapy would be helpful for them. And what is to point out here is that I believe that one of the key components of our ability to reach these target populations was that they wanted therapy and we offered it to them. They had positive ideas about therapy. So they thought that with the help of a therapist, I'll finally be able to reduce my suffering. Most of them thought, yes, that will be how therapy can help them. Most of them thought that therapy was going to be helpful in specific ways, that it wasn't going to harm them, that it wasn't just going to be a waste of time. And I think that does contribute significantly to being able to reach that population. I say that because we're also implementing this lay counselor-based problem-solving therapy intervention for youth in a community setting in Botswana. And so this was done in a HIV clinic setting in Botswana with this cohort that you see here. But we've just worked with a cohort in the community, and these numbers are actually significantly different. We have a number of young people who are skeptical about therapy and about therapy's ability to reduce their suffering, to actually be hopeful that nothing bad will happen, that there won't be any stigmatizing events associated with being seen by a therapist. And so, most of these young people in this slide that you see here are from the capital of Botswana, Gaborone, but our young people in the community are in a more rural area, and we see some shifts there. So I do believe that this is a key component of being able to reach target populations. I want to just share some of our qualitative data that also shows what I think is important about reach and why these positive ideas, that they did have positive ideas about counseling. And so it says the counselor showed me options to choose from, like in order to solve my problems. And the interviewer says, are there other thoughts that you would have for other people who would want to see a counselor like you? And the young person says, yeah, I think it's a good idea to see a counselor because you need someone to help you solve your problems in life. So yeah, that's a 14-year-old who was in our original pilot before we were taking efficacy data. So who is missing and why? In our community setting, as I mentioned, where clients and counselors both have more social determinants affecting their response and engagement as lay counselors, in these community settings, we do not see the same rates of agreeableness around therapy. And interestingly, we thought that a community setting would decrease a lot of the logistical barriers to attending therapy, but it's probably that they have other social barriers that are getting in the way of their attending therapy sessions. And so they're no more or less likely to attend their sessions so far. This is just preliminarily. Like I mentioned, they have more varied perceptions of therapy, though they're generally positive. So all that to say that reach, we have been able to reach in our first pilot and our second pilot. It remains to be seen, but I think we do need to be thinking about how attitudes to therapy are going to affect our mental health engagement, even with lay counseling programs. Now, going to effectiveness in our Reaim model, we don't have power for effectiveness or efficacy, but the friendship bench intervention is the problem-solving therapy-based intervention that our program was modeled after, that our training materials are modeled is an evidence-based intervention that shows significant reduction in symptoms in a variety of populations. So for us, we just wanted to understand, is there any signal at all when it comes to symptoms of depression or anxiety or just general mental disorders? And so we did ask the participants of our pilots to fill out a PHQ-9 and a GAD-7 and a SSQ, which is the Shona Symptom Questionnaire, which is a general scale that's used in Southern Africa for mental disorders. And each of those scales showed that there were a reduction in reported symptoms between pre and post interaction with the lay counselors. But I want to highlight that when we talk about effectiveness and implementation, if we're using the Reaim, enhanced model, we do have to think more broadly about what's actually happening and look beyond just mean scores. And so what I want to show you here is that though most of our patients got better, so 66% had a reduction in their symptoms on the PHQ-9, 71% had a reduction on the GAD-7, all had a reduction on the Shona Symptom Questionnaire, which I think is super fascinating. But there was no change or an increase in symptoms in a minority of patients. And so when thinking about effectiveness, I am, exploring who are these folks who had no change and who are the folks that increased. So overall, the population did well, but what are the characteristics of those who didn't respond to the intervention and why? And that's something that we're exploring. So in addition to the measures that the sort of pilot funders wanted us to gather and that they wanted us to keep clean in our grant application, our stakeholders had asked for other measures of success. And one of those measures of success was quality of life improvements, things like self-esteem, mood, or productivity. Actually, the stakeholder group was really specific about wanting to support adults who were functional, which I think is really consistent with things that we want for adolescents often. They also wanted client testimony and feedback, and then skills in goal setting and decision making to be measured. So we were able to do some of that. We were able to get some client and counselor feedback. So I'll just share some of what was some of my favorite feedback, because what it does is it emphasizes how the stakeholders were kind of on it when it came to what their recommendations were. And so the clients loved that their counselors were younger. So again, we had our first set of interviews happened in younger teens that had just done a pilot without any pre or post efficacy, quote unquote, data. And so that just so happened that this cohort was younger. So this younger lay counselor says, our client says, when I talked about my mom, that she does this and that she would obviously at that point say, yo, I know that one. So it was easy for me to go into deeper issues because I felt that me and her were on the same page. Another client says, I was able to open with the person, their counselor, because he was my peer. He was not that much older. I was able to use words that he was able to understand. And we actually heard this many, many times about using words that they were able to understand. Clients also gained hope. So, some positive indicators for life. So when the interviewer asked, what would you say is the best part about sessions? What did you like? And the client says, it taught me never to give up in life. And this is a 15-year-old male. From the counselor side, we were actually really interested in how the counselors were affected, the lay counselors were affected by being lay counselors, particularly as young adults in settings like Botswana and other low and middle income countries where young adults often have very high rates of unemployment. And after they get out of school, they kind of just are struggling to find purpose. So these lay counselors, they're just amazing. They said a lot about how being lay counselors changed their lives. And I'll share just a few of their thoughts, their feedback. Counselors were happy, impressed with clients' new skills. So the interview says, what would you say is the best part about the whole thing? And this is asking the counselor, and the counselor says, well, my client's reflecting back what was discussed and her achievements. That was actually really amazing, listening to what she had achieved. What we would like to measure next is some of those things that our stakeholders asked us to measure. One is skill building. So what are some measures of problem solving that we could use to actually understand whether these young people are gaining the specific skills that we want them to gain, and how long lasting is the effect on their mood symptoms. We'd also like to measure quality of life outside of our qualitative interviews, so using some formal quality of life skills. And we also want to make a conceptual model of how lay counseling might work, similar to this Lambert model of common factors that add to their therapeutic effectiveness. What is the conceptual model of lay counseling, and is it any different, and should it be seen differently? I have some ideas about that, but I am hoping to work with a psychologist to create a conceptual model of lay counseling that we can use going forward. So the next part of the Reaim framework is adoption. So how are organizations, how are settings representative, and how are you finding them so that you can set up for something that is able to be maintained. So for our lay counselors, we found that adoption actually has multiple steps or layers. And one is that the lay counselors are sort of implementing the problem-solving therapy. And so we, as I mentioned, find them from varied backgrounds. And like I said before, there's no demographic pattern of dropout. So it's sort of the ones who made it, you can't really predict. And then from a leadership standpoint, we were able to set up these implementations of this lay counselor program in now 3 settings. And what's key to adoption of the intervention in our experience is that the people who are assisting in running the program need to be involved in any needs assessments so that they understand the scope of the problem. When we did our first intervention with the quantitative data that I showed you in the HIV clinic, the team that helped us run the lay counseling program also did the screening for the symptoms of depression and anxiety, and they thought that we needed to implement the lay counseling program like yesterday once they started seeing the numbers. It also was important that we made a deliberate relationship with the leadership at the start, and so some of that was actually involving them in the stakeholder meetings, and some of that was making sure that any operating procedures that we would put in place involved the leaderships actually taking an active role. When we had our stakeholder meetings, those 5 and 2 meetings that I mentioned earlier, we actually found that one of the common feedbacks that we got was that the that the stakeholder meeting was one of the most interactive meetings that they had ever participated in. And so that deliberateness helped to set us up so that when we came to implement the program, they were excited about continuing the relationship and also understood what it was that we were trying to do without being in a very busy setting of trying to figure out, you know, what is this all about? I've got patients to see, blah, blah, blah. And then when it comes to settings, you know, the stakeholders are recommended that we put, you know, friendship benches or late counseling programs in places that adolescents go, hangout spots, other health facilities. And so we try to do that. You know, I mentioned the community-based setting that we are trying to implement our version of the late counseling program in Botswana, in the more rural part of the country. And again, you know, it's about making sure that that leadership is involved and aware of the specifics and the settings that we chose. We're trying to address the common logistical barriers that adolescents often face: transportation, time, school schedules, things like that. But we also have to think about how settings are associated with different issues of privacy. So if you have a friendship bench program at a school or in a public place where everyone can see, how do you balance privacy while also making a space more accessible in a place that's more fun? And do they all agree that having something like this in a place that's fun is the right place? So we've been trying to balance that out to make our adoption more responsive to the stakeholders while also considering some of these other factors. So our lay counselors, when it comes to adoption, I think one of the key factors for why our lay counselors decide to do it is because they felt like they were the right people for the job. And, you know, aside from the other benefits, like feeling like they're a part of something, I do think that it's important for people to feel like they're able to do something useful. And so one counselor said, I can easily communicate with the clients, interact with them well, you know, make them feel like they're in their comfort zone so they're able to talk. Another counselor who, again, I believe that part of the adoption and our ability to be representative, particularly of not super highly educated young people, is that they gain from the interactions. And so one counselor says that they gain better skills of relation. So it strengthened my counseling skills and my listening skills and my understanding of the psychology world. And it has made me accept people's energies differently, as any working environment would. Like wherever you work, you know, you're going to meet different people and you're going to have to accept who they are. So these kinds of things not only lead to adoption of the intervention, but also give them skills that are transferable, that they feel like will set them up for other opportunities in employment or what have you, which is actually quite important in this age group. And then the other thing to consider about adoption is sort of what's the cultural context in which this adoption is occurring. And so I mentioned when we talked about reach, about, you know, how do you get representativeness? And I think part of it is, you know, feeling like, you know, therapy would be helpful. Well, getting systems and settings and organizations to be involved is also understanding what the cultural contexts are and trying to, in some way, address them. And so one lay counselor brought up, again, and this is why I think having lay counselors, especially young adult lay counselors, was ideal for our context, because these young adults were able to sort of push the boundaries of how they thought about young people and their mental health. So this young person says, you know, working with the youth, etc., highlights everyone has their own way of solving problems, but then we never really, in our culture, in this era, we don't really see it as something that is very common, just to see a child stand alone and then do their own decision-making stuff without involving the parents. And so this emphasizes that doing an intervention with a young person where they are taking the lead is culture pushing, and something that they were able to adjust to as younger adults. So some of the things that helped with adoption at the organizational level were that we were integrating the lay counselor program into pre-existing structures that were enhanced. And so, for example, in the HIV clinic, they had a psychologist, a master's level psychologist who was overwhelmed. And so we worked with her to create a workflow so that the lay counselors can support her work. And in the community program, they had a social worker. And again, we were able to integrate into their intake process potential referral to the bench program. And because it's a community-based program that sees youth for a variety of programs, they were able to send them from the different programs that they were participating in for their sessions. And so that also is associated with the obvious needs. So if you have a psychosocial support department in your community organization or school or clinic, then you're probably already going to see the obvious need. And so the organizational will was easier for them because they had seen that. And that was also part of the reason why we got them involved in the needs assessments, because the adoption was related to their understanding of how big the needs were, because they had just seen how significant the data are. And then some of the things that made it hard for organizational support to take on, even in long term, was competing projects. So some, especially in HIV and in many countries, particularly in Southern Africa with high burdens of disease, there are tons of competing projects and programs. And so getting your program integrated long term into clinical care can be difficult because of that competition. The lay counseling program, which I'll talk about in a second, is not free. It is, nor should it be. It is financially less expensive, but it is not free. And so people at an organizational level might say we have no funds left to support any of this. And then the professional research challenges. So just like the lay counseling programs are not free, they also require professionals. So even though lay counselors are there to extend the work of professionals, they need professional supervision. So there has to be some professionals involved in the program. So I'm going to talk about implementation and a little bit quickly, just to highlight some key areas. There's lots of specifics that we can talk about with questions, but I'm going to talk about some key things that we thought were important. So remember that the implementation model that we used was largely based on the stakeholder guided theory of change map. So the important thing to know is that our lay counseling program is not the Friendship Bench. The Friendship Bench is a combination of psychoeducation, problem-solving therapy, and a program called CKT, Circle Comboratos, which is essentially a group support program that often is tied to income generating activities and just, folks meeting up after they've had their 4 to 6 sessions in problem solving therapy with their lay counselor. Obviously, each of these components can affect somebody's overall mental well-being. And so it's important to note that the Friendship Bench involves all 3 of these elements. We did not have a CKT or group support or financial generating section to our lay counseling program, which our lay counselors named Safe Haven. Actually, one of our lay counselors made that logo. We had psychoeducation and we had problem-solving therapy, but we did not have a CKT. We actually tried to think about what a CKT equivalent would be like for young people, but we actually had a really difficult time creating a model that was adequate. And so we said, let's just go with the psychoeducation and the problem-solving therapy, since the problem-solving therapy is doing the real work of the intervention. And so our intervention, our lay counseling program, Safe Haven, is psychoeducation and problem-solving therapy. And so I'm telling you that because it's important to know adaptations and be clear on what you think are the active ingredients. So we also made sure that we trained and established significant support for our lay counselors. So we had weekly meetings. Every other week was therapy, group therapy for the lay counselors. And then the other week, for the first 6 months, we actually did coaching sessions. So the training was actually a week-long training done by the Friendship Bench folks in just the problem-solving therapy and psychoeducation parts of the Friendship Bench training manual. We also did fidelity checks with recorders. We had them choose between recorders and somebody watching their sessions, and they unanimously decided on recorders. And we actually had to like hide them in the back of the room. They all knew that they were being recorded, but they would get nervous when they would see the recorder. But we were able to do fidelity checks using recordings of each lay counselor sessions. And then, like I mentioned, we would do weekly meetings with them to do skill building and review, and also provide them with mental and emotional support. For the recruitment and retention, our stakeholders had asked that we do, referrals from folks and advertisements, but we couldn't actually recruit from advertisements because our program was just so small. And we hope that in the future, one day we will have a larger program that we can recruit in such a way. There's also, but what we actually did was we set up screening programs that then were natural recruitments to the program, and then we did self-referrals. And then for retention, we made sure that we followed the guidance of the team and were flexible. We're really mindful of the complexities of the use schedules, both the counselors and the clients, which was the biggest issue. And we did provide high quality, non-judgmental services. One client said, the lay counselors were like a friend. And so that's where we get the non-judgmental, high quality service. You felt like you was somebody casual and also like you were just talking to a friend. Counselors said also that, they felt that being a young person helped them be on the client's level, which also helped them create high quality care. So how was our implementation? For our first site, our HIV clinic site, we had 57 eligible, 48 that were enrolled, and then 35 that completed sessions. And I showed you that those numbers of their pre and post tests for the symptoms of depression and anxiety. And then actually 10 completed 1 to 3 sessions, and 9 out of those 10 actually stopped because they just felt like they were done, and 3 were lost to follow up. So that actually leads to the question is, could this be used as a brief intervention? The 4 to 6 sessions are really 4 to 6 sessions of problem-solving therapy. We just go through problem-solving therapy over and over again. So we know that there is evidence for single session interventions working for some diagnoses and some populations. So maybe this could be a single session intervention, and it could be even less than 4 sessions that work, or it could be a very brief or micro session intervention. But then the question is, for those who did less than 4, will they need booster sessions? And so we'd like to follow them over time. And so that's what we are doing, that and many other next steps for implementation. So I want to just highlight that one key element of understanding implementation is understanding the cost. So each of our lay counselors was screened for mental health concerns. They had the training, they have the booster sessions, and they have group therapy. Group therapy, as many of you are probably well aware, is not cheap, but they deserve quality group therapy, and they deserve to have supervisors that are trained. So although they were able to see see a lot of patients because, you know, there were many lay counselors. And we did pay them, though it wasn't, you know, an exorbitant amount, paying them, paying their group therapists, and paying for their supervisors, all added to the expense. And so it's important to know that it's not a free program, and nor should it be. The same barriers and facilitators were at play for maintenance of the program as for adoption of the program. And we're still yet to see as how the maintenance of the skills or their improved behavioral health outcomes are at play. So I just want to take a minute to say for the junior investigators out there like me, that research is hard, particularly in global health. There's a ton of things that make research significantly more difficult. It's already difficult wherever you are, but it makes it more difficult in global health. It's still worth it. It teaches flexibility, a chance to grow. Rejections teach us how to do better. And even COVID-19, which really derailed our program, teaches us what matters most and gives us a chance to slow down and ask some more interesting questions. So with that, I'd like to thank my team, funders, my junior team that helped me put these slides together, and our lay counselors. Thanks.
Thank you, Dr. Brooks, for walking us through this research program that has been ongoing and the initial results from the studies that you've led and the treatments delivered so far. Dr. Besti, I'm wondering if you want to pose a comment. I'd like to encourage others to write in any questions. We have just a couple of minutes.
Yeah, I just want to say thank you so much, Dr. Brooks. That was fascinating. And I personally was really just thrilled to watch and hear you use the Reaim Framework to do an implementation science study. As you know, implementation science is a big type of research here at UW. So it's really just enjoyable and fascinating to watch your research using the Reaim Framework. So thank you for sharing that really great research in global mental health using implementation science frameworks.
Thanks. It's really, really helpful, actually.
Yeah, I guess, you know, we do have a question.
More of a comment that came in regarding sort of meeting people where they are in life, and so much is misunderstood about youth behaviors. Yeah, any questions? Well, I'd like to pose one question, maybe just in the remaining moments. I was interesting to hear about measuring quality of life improvements. In adults, it can be challenging to observe that over a relatively shorter course of treatment. And I wonder if that changes more rapidly in adolescence, or if you can observe changes in quality of life with this intervention.
So that's part of the reason that we actually didn't observe quality of life or measure quality of life in the beginning, because we knew that it was going to be a relatively brief turnaround in terms of our engagement with the participants. But now that we have a little bit more research infrastructure, we are going to follow them for longer. And we think that that's an appropriate time to be checking for some of the quality of life measures. But that's an excellent question.
Thank you. For that response. Two things came in. One about recruiting young men as counselors. You had so many, says Dr. Collins. Will you comment on that? And the other is related about target population going forward for fully powered studies. And I wonder, now that I'm thinking, I wonder if that would include lay counselors and individuals receiving treatment. But perhaps you could talk about that.
So in terms of recruiting men, for the lay counselor program, we recruited from other leadership programs. So there are tons of leadership programs in Botswana, and often they sort of end and that's it. So we actually had a significant number of people to choose from. And when we reached out to them and told them about the program, we interestingly got a lot of young men. I think part of that is because the first group of recruitment, the first recruitment area was from the HIV clinic that has mostly perinatally infected youth living with HIV. And those youth are pretty much 50-50 because they're perinatally infected. As they get older, those numbers take off, the female numbers take off. But that's how we were able to get a lot of young men. from other leadership programs. Lessons learned about the target population. Yeah, I think that one of the things that we are going to do is do more exploration as to why we got who we got. And I think that part of it is because the people that we participated wanted therapy. So is there a way that we can get folks who maybe have higher scores, more moderate, less mild, by targeting them or understanding specifically what their needs are, or maybe they do have stigma that's getting in the way. So we did our best to understand the implementation areas around the people who did participate, but our next step is actually looking at the people who chose not to.
Great. Well, Dr. Brooks, I know we're pretty much almost up on time, but we do have one more question from Dr. Jody Weiserheit, who's also the chair in the Department of Global Health. She asked, reciprocal innovation is a big focus in global health now. So from what you've learned, what would you do differently in applying this type of approach to mental health care for adolescents here in the United States, or who you see in Philadelphia?
So I love that question. We actually are thinking about finding a way to do it in Philadelphia. The key thing to me is that young adults that get to be lay counselors gain a lot from this work. And there's ripple effects to their friend groups, the way that they interact with other young people. It really transforms the young people. And so, I've been thinking, what if we just trained all the young people in problem-solving therapy and how to engage one another? How could that affect classrooms, across the nation, in just changing the frame of how people engage with one another? I think that would be really fascinating and needed in everywhere. Australia, UK, US, we're all struggling with our young people's mental illness, and so what can we do to try to give them skills to give back to each other?
Well, Dr. Brooks, thank you again for presenting today at this joint Global Health and Psychiatry and Behavioral Sciences Grand Rounds. We've gone just a couple minutes over, so we'll need to conclude for now, but thank you again.
Thank you.